have Dr. Michael right beside me. So without further ado, here's Dr. Michael.
Oh, great. I guess a lot of people know me already, so maybe that's, I'm not sure that's a good sign or a bad sign, but thanks so much. Okay, it's my pleasure to be here. Thanks for staying for the last part of the day. And so, it's going to be, I can't see there. So I'm a scientist, so don't ask me any clinical questions. I won't know how to answer them. But I guess what I will try to do in the next 30 minutes maximum is to tell you what we're trying to do, which is basically try to learn from your disease and maybe try to find new treatments, which is what we call building preclinical models. Oops, this one. I have to figure this out as well, okay? Or liquid biopsies, which is a new way for detecting the disease. Okay, so this is, maybe you've heard about this, what we call translational research program, and the idea is that you take the human disease in the lab, you try to understand it, hopefully find new treatments, and then try to take that back to the clinic. So our goals are to be able to detect the disease earlier. I know for what I hear more and more about patients with neuroendocrine tumors is that they had the disease for many, many years. I'm not clicking anything, I promise. But also to be able to monitor the progression of the disease. I know it's a long journey, and you have to undergo a lot of imaging, and especially for patients that live in areas in Canada that they don't have access to all the fancy imaging, maybe we'll find a better way to do this. And, obviously we want to understand better the disease and hopefully try to find new treatments, especially for more aggressive types, because we heard there are so many subtypes and subtypes in neuroendocrine tumors. Okay, so but why do we need personalized treatment? So if we look at 20 years ago, how we look at cancer. So you can take the grapes, and if somebody had a breast cancer, we'll say, okay, this is grapes, and if you had a neuroendocrine tumor, we'll say, okay, this is apples. And probably now you know from breast cancer, most people, they know that we can have a hormone positive and triple negative and different subtypes. And the idea is, can we do the same for neuroendocrine tumors? So here it is. If you take the apples, not every apple is the same. So if you take the red delicious, because I know everybody, now you are expert, most of you know more than I do, and believe me, you do. So the red delicious, we can call them is your G1, right? Low Ki67, right? So if the pathologist sees that, they know exactly what they're going to do. They tell you, okay, everything is good. And we call the golden delicious, it's your G3, very aggressive. Again, we know what we're going to do. But if you have this Fuji or the Honeycrisp, that's kind of in the middle, you're at G2, we are not always sure what we're going to do in the clinic. So that's why we try to bring those tumors back in the lab and trying to find better ways to categorize them. Also, the other thing that is very unique and fascinating for me for neuroendocrine tumors is that you have a G1, which the tumor really doesn't replicate. It's very slow. But then you have patients with widespread metastasis. That's, for me, as a scientist, it's unheard of, and it's very, very unique to neuroendocrine tumors. So, okay, so here are two tumors. This is from a mouse model, but it's the same thing for patients. And if I were to show you the Ki67 between the green and the blue, there is no difference. So if I were to give this to a pathologist, you would say both green and blue are exactly the same tumor. But only the green tumor is able to metastasize. And this is what we're trying to understand. And for two reasons. One, And I think yesterday, Dr. Calvin Lowe also said, if you have a tumor between 1 and 2 centimeters, they are not 100% sure what they're going to do. And if you don't have metastasis at that point, they are not sure whether actually you will develop metastasis one day. So we do want to find molecular markers, not Ki-67 and not chromogranin, that will tell the clinician and the pathologist at this point, this patient already is susceptible to develop metastasis, or maybe already has a micrometastasis that we cannot see, so you have to follow him up more, right? But also, what's the difference between type A and type B? Can we find something that we can target only type B, right, tumor? All right, so this is summarized here. This is what we're trying to do. So I'm at Sunnybrook, and the advantage being in one of these big centers, obviously, is that it's the volume of patients. And for me, the volume of patients you get at Sunnybrook is representative, so that you're going to get in Vancouver. So I think the advantage that we get all different subtypes of neuroendocrine tumors from G1 to G3 and all different aggressive subtypes. So when I joined the Sunnybrook, which was only 2 years ago, I decided that I'm going to work with patient samples because I did all of my training working with mouse models, and I felt that it's not a waste of time, but with mouse models, you just learn only one small subtype. When you work with patient samples, it's a completely different story. So yeah, we said we're going to put patients in the middle, and this is what they do already in the clinic of Dr. Simran Singh. But we wanted now to extend this and put this new window up there. Can we use patient samples to develop models, find new treatments, develop liquid biopsies? So how are we going to do this? The first thing we decided we're going to do is what we call Biome Bank. And this is not the bank where you have your money, or we think we have our money. But it's a bank where actually we take samples from patients, and we can store them indefinitely in a good condition. That the theory is that even if we don't have a method today to understand the biology of your disease, maybe we're going to have a method in 5 or in 10 years. And maybe you're not going to benefit, but maybe you're leaving behind a legacy that will benefit the next generations. So this is a very important endeavor, and not many centers can do this because it's very costly. And also not many foundations will give you money. So all the money for this biobanking comes from Sunnybrook itself. Okay, so we can collect samples, and we know all the clinical history as well. So we can always go back to the samples. And this is the way that it's done. I'm going to go through it in the next slide. So there are 2 samples we wanted to get from patients. Usually it's a surgical specimen and plasma. And the way we do it right now, if we have a patient that we know will come for a surgery, we'll approach him. We have a consent form. We have a team that is not part of our group. That's also very important, so there's no conflict of interest. They will approach the patient. They go up to him, and they ask them whether they like to give the surplus of sample, okay? So this has nothing, it will never affect the treatment or the diagnosis of the disease, and I'm going to show this here. So if you have a surgery, and then your sample usually go to pathology, and then from pathology, they will do what the pathologists call FFPE sample. So they will take a very small, like 10% of the actual surgical specimen. And that's what they give to the pathologists, and they will do the Ki-67, which we learn in the session in the morning. That's how they do the diagnosis, and maybe chromogranin. But believe it or not, the rest of the sample, 90%, in all of the samples, in all of the centers, they just throw it away, right? They can't keep it. It's impossible. But what we convince our center to do is that now we have to keep everything, so we don't throw away anything, right? And we do 2 things. One is part of the sample we snap freeze, and that's a sample now that we can bring back at any time in the future, and we can do any new methods of understanding biology. And the other part, it comes into my group, and I'm going to show you what we do now with these fresh samples. So this is a sample that comes directly from the patient, and we can use it to understand what's going on at the patient at the point where we get the sample out. The second one is we collect plasma, and the idea is the same. We biobank some for the future, and then some of it, again, comes into my group, and this is now is taken off, I'm going to tell you, from a couple of other groups who are more experts than I am to develop liquid biopsies. All right, so we're going to start with liquid biopsies, but before I go there, I'm just going to show this slide. You need really people who really are willing to do this. You need people who are going to champion this, right? Not everybody is willing to do this. We are lucky we're an academic center, so Dr. Calvin Lowe and Julie Hallett, people from Toronto, they know them, they are our surgeons. They are willing to give us the samples, and then we have obviously a whole team that will, as I said, will consent the patient, and then Dr. Nilakshi Kulathunga is in my group, and she will take the sample from the pathology and bring it to our group. But for me, and I want to say thank you to all the patients and families, because none of the patients ever declined to give samples for research. And I think this is something as a patient you have to let people know, because a lot of times when you go to the research ethics boards and you say, I want to do this, they say, oh, patients is going to, and they're not going to say yes to it. But no, that's not the case. It's really amazing. Okay, so I'm going to go back and I'm going to talk a little bit about liquid biopsy and what's a liquid biopsy. So the reason we want liquid biopsies is, as I mentioned, Ki67 and chromogranin, they have their own problems, right? So Ki67, if you have very low, it will tell you that, okay, this disease is low, this is the treatment. But if it's in the middle, we don't always understand what's the right approach, and hopefully we'll find better approaches to slice the pie and understand things. So we think that with liquid biopsy, we're going to be able to do early diagnosis, we're going to be able to monitor disease, but also the response to treatment. So what's a liquid biopsy? So the biopsy usually you get it goes into the tissue, right, with intervention. But liquid biopsy, you get a sample from the blood circulation. And why do we do that? Because tumors, you will think about it, they just shred a lot of material in the circulation. You saw in the morning from the interventional radiologists that they are very vascularized, especially in neuroendocrine tumors. So there's a lot of things that go into circulation. So we can now look at the blood, and we can try to understand whether you have a neuroendocrine tumor. So, and Dr. Hayes had mentioned yesterday the extracellular vesicles. So extracellular vesicles, so if you think this is the tumor up here, this is the nucleus, it's like kind of this bilayer. It comes from the cell, from the cancer cell itself. But the advantage is that now, if I take this extracellular vesicle, it will tell me exactly what's inside the tumor. It will tell me whether you have a tumor that is less aggressive or more aggressive. So I can really understand, even without going to the tumor directly, what kind of subtype of tumor you have. And just think about it, this is not the best example, but think about it like you go into a field and you have a lot of flowers, but you can't see the flowers, and you can just collect the spores, and then you can go back and just really understand what flowers you had. It's kind of almost the same idea. And so again, here is the thing, doing a liquid biopsy and then going back and then knowing exactly what's in the patient, whether it has type A or type B. And in the liquid biopsies, we look into these small molecules that we call microRNAs. And why we look into these small molecules, just think about microRNAs as the orchestra, as the maestro in an orchestra. So it does tell the cell how to behave. So they are really important about the cells, whether they're going to be benign or more aggressive, whether they're going to metastasize, whether the cells are going to get into the circulation. So we can understand a lot about the biology. So now this is early days, and I'm not going to show specifically what microRNAs we use, but we started with a cohort of patients that we know that they don't have, at least to the best of their knowledge, and neuroendocrine tumors. So they don't have a net diagnosis, and we took samples also from patients that have net diagnosis, and we look at one of the microRNAs here. So every dot, it's one patient. And what you see here, it's the levels of this microRNA in the exosomes, right, in these particles that circulate in the blood. So you see here in the first one, a patient that without a net diagnosis, it has nothing, or one of them has very little. But you see this is a patient now that has a lung neuroendocrine tumor, and you have very high levels of this biomarker. And these are not the recent data, but we expanded the cohort, and this one, it looks really good. Somebody asked me on Friday what you're more excited about. I'm really excited about this, and this is, I have to give all the credits to Dr. Neil Renwick from Queen's University, who was the first one to discover this microRNA, and then with Dr. Hon Leong from my institute. Now they paired together with other scientists, and they're trying, and Dr. Simran Singh, and they're trying to further develop this. So I hope that this one is not going to die at some point during the process, because when you, and every time you're trying to develop a clinical trial, there are many steps you have to go through it. But I'm really excited. I hope I will see this one day in the clinic. I think it really is going to enable us identify neuroendocrine tumors at the very early stages, at the very least. It might also allow us to monitor disease progression and response, but at the very least, at least early diagnosis. Yeah, so now we are doing the further validation, and again, all the patients that come now at Sunnybrook, we ask them to give plasma, even if they don't go undergo surgery. At any point in your journey, if you come now in the hospital after PRT, before PRT, and that's really good for us, because now we're going to correlate the levels of this microRNA with your disease, right? How widespread the disease, whether if you respond to PRT, are the levels of this microRNA of these markers going down. So it's a really good study, and the fact that we see so many patients is going to allow us to learn a lot. Okay, so the other thing, and this one I want to mention, this is it's funded by Cnets. This is again, we went back, as I said, for the last 20 years, the samples we collect, but we keep a very small piece. Can we do anything about this? So we went back and we convinced our pathologists to bring all those tissue samples to us. And what we do is shown here. We take robotics that they go into each of these samples. They take a hole, and what we call, they pull these biopsies together. So we make a small, what we call a tissue microarray that has 600 samples. So these are 200 patients on the same slide. And these now, using now this TMA, allow us to now screen for new markers that hopefully will perform better than Ki-67. So even patients that they were there 20 years ago, now they can contribute to new findings. So I'm going to switch to what we mainly do in my group, which is now building what we call avatars from the samples that we get from patients from that's the surplus of surgery. So here is the idea: if you undergo a surgery, part of the sample we call the fresh tissue will come to our group, and we'll do two things. We build this what we call an organoid, and I'm going to show you some more images. Or on the other side, what we call a xenograft. The difference really between the two is that in the case of the organoid, you disassociate the cells and you let them grow back to this sphere. But in the case of the xenografts, I will show you a video. You implant them into an egg. Okay, so first I will show you a few images about the organoids. So here, what you see on top, this is the Ki-67. It's the nucleus of the cell. So these are all cancer cells, and we use different dyes. The one is from the nucleus, and this tells us the different states of the cells. And with these associated cells, we put this, and we can monitor them, how fast they grow. And here it is, and then we can also image them. And not we can image the whole organoid, but we can actually go through this sphere from top to bottom, and we can see every single cell, how it behaves. Now, this is important? Because now we can derive from one patient thousands of these organoids. And you can see this a 384 web plate that we use. So this one will have a 384 organoids, but from a patient, maybe we can do 5 or 10 of these. It depends how big is the specimen. But then what do we do about this? We have robotics, and now we do the screening for drugs, and this is something we're going to start. And the first thing we're going to start with is with FDA-approved drugs. And the idea is that you have 1,000 drugs, and you screen them for neuroendocrine tumors. These are drugs that were never tested whether they're going to work for neuroendocrine tumors. And the idea is that we have a new drug now. It's already FDA-approved. If we find that they will have a response in neuroendocrine tumors, then we can take it into the clinic and hopefully have some preclinical or clinical trials and bring it to the patients really early. So with the methods we have, again, we can see, for example, all the things we always see. You have a sample from metastasis. This is from the same patient. The sample from metastasis, it grows much faster than the primary tumor. Metastasis is always more aggressive. But also what we learn now is that the metastasis behaves very different from primary tumors. So this is a drug that it's used for neuroendocrine tumors. So if you give this drug to the primary tumor sorry, will shrink, but you see that it doesn't affect at all metastasis, right? So what we want to do is to find drugs actually it will kill metastasis, because primary tumors, most of the time, you will remove them anyways through surgery, but what stays behind, and the big problem is metastasis. So this is what we do with the organoids, which we can go up to 1,000 of organoids. But then the other thing we do is we just take these tissues and we implant them into eggs. And here there is a video. Let's see if it's going to play. Yeah, go ahead. So this is how we develop what we call the PDX models. So what you see, really, we get a lot of eggs coming in the lab, and it can be chicken eggs. We incubate them for a few days to fertilize them. And then we wash them, we sterilize them, and then we crack them and we put them in this dish. So now in the middle you can start seeing this, the chicken embryo start developing, but it develops this vascular network that now allow us to take the piece from the tissue from the patient and graft it in that egg, and what we call chorionic membrane. So now what you see here, it's a tumor from a patient. And what we can do after that, we can actually go and treat this one. And now we can really understand in real time how the patient will respond to the treatment. And aside we also we have a biophysics department, so we can use ultrasound. And using ultrasound, actually, we can visualize the tumor, how it's growing, but also what you see here, this is the vascular network. So this is the vessels in the tumor. Thank you. So this work that it was the facility was set up by my colleague Dr. Hon Leong, and but it's the first time that it's done for neuroendocrine tumors worldwide. So Sandberg is the first center that can do this with samples from neuroendocrine tumors. So here's some examples. These are from the same patient. It's a patient with a small intestine neuroendocrine tumor, and on the left side you can see Now this is the primary tumor, and on the right side, this is the liver metastasis. With ultrasound, we can see how big the tumor is, and then here on the bottom side, we can actually see the vascular network. This is the blood flow in the actual tumor. And we can monitor the volume and, again, the vascularity. So we can use these parameters to understand whether the tumors will respond to treatment. So this is how a tumor looks like. So on the outside, what you see highlighting with blue, this is the choroidal membrane. This is from the cheek embryo. But the rest of the sample, this is actually a tumor from the patient. And this is exactly how the tumor looks in the patient. And the big advantage is that not only we keep this, let's see here. So these are the cancer cells, right? Or the tumor nest. But a lot of times in cancer biology, we know that it's not just the tumor cells, but it's also the stroma. So just think about it as you have your family and your friends, and what you are is not just you, it's just your family and your friends. And let's say you go through something and your family will support you and your friends will support you. The same thing is unfortunately for cancer cells. What we call we call it the microenvironment of tumors. It's really, really important whether a tumor actually will respond to therapy. And to understand this is probably the only model that will allow us to do that, because it's the only model that allows us to keep the stroma. Sorry, I'm going back and forth. So as I said, it's early days, but we're really excited about this. And you are all familiar with chromogranning. So this, again, showing with chromogranning, staining, what you see as brown is the cancer cells, and the rest, this blue, again, is a stroma. So we've done this now. I think this is outdated data, but I think we've done this now for at least 10 patients. We developed over 100 of these PDX ovos, and the success rate is really, really high. So now we want to move into the next step. And one of the questions we have is what happens, for example, when you give PRT therapy to a patient? What happens in the first hour, in 2 hours, in 7 days? How do the cancer cells respond to PRT therapy? Do they upregulate something else? Why some patients will respond to PRT therapy, some of them will not? And can we find a ways to make PRT therapy more efficacious? And that's our number one priority in the lab right now. Okay. So these are the two programs now that we have at Sunnybrook. One of them, on the one side, we're trying to find new treatments using both these avatar systems, the organoids and the xenografts on top, and on the other side, we're trying to find new biomarkers. It can either be tissue biomarkers or liquid biopsies. So I think now at Sunnybrook, to my knowledge, we have the only biobank of SNAP frozen neuroendocrine tumors. And again, I think because of the volume, my hope is that we're going to represent all patients that we have in Canada. We are the first center in the world to establish high-volume net organoids. And this is not exaggeration. We are the only place that we can do this in the world. We are the first center to establish, and it's the first time to show that we can do xenografts with neuroendocrine models. We are building some of the largest tissue microarrays, and also I think with our colleagues at Queen's University, hopefully we'll bring the first liquid biopsies for neuroendocrine tumors. The last two slides, it's the reason I was here on Friday and the reason I'm here with you today, because for me as a scientist, I had my lab only 2 years now, so I still remember what it is to be a journey and be in the lab for days and nights and weekends, and working for 5-6 years in a project. So, but also I do have relatives with neuroendocrine tumors. So I understand you. So for me, it's very important that these two journeys are not two silos. And it's not only for neuroendocrine tumors. I hope that this is going to be for every cancer type in the future, that patients will understand what's going on in research, and researchers will know that behind every sample you get and come in the clinic, there is a patient behind it. And this is something I told my trainees. I know that sometimes the samples comes at 6 o'clock on Friday and they have to stay until midnight, but I remind them there's a patient behind it. They have to, and I expect them to stay and take care of everything we get in the lab. But I do want, and I'm going to do this, is one of my big aims, that the two journeys, they interact. So with the help of Cnets, we want to get patients that will interact with our group, and it can be just for a coffee. But it's a reward for my trainees. When I told them I'm coming here this weekend, they were so excited. And they really want to interact with you. They are very excited to tell you what they are doing. And we know that most of the times experiments fail, and maybe what we're trying to do today is not going to go anywhere, but we're going to learn something, right? So this here is what we're trying to do in different steps, but for me, patients should be involved in every step. Even when we build a consent form to come and ask you, can we have your sample? We should know, do you understand the language? When we come and we will call you, and for the script, what we write down, how we're going to ask you, what's a good time for a neuroendocrine patient? Is it okay we call you 24 hours before the surgery? Some patients are okay even in the morning before the surgery, but some of them are not, so we have to understand all this, right? And for me, patients should be part of the whole journey. Even at the end, when you have data, we publish them in this scientific journal. Sometimes we can't even understand when we read papers. Imagine patients, right? So we want patients to come to us and explain to them and write together a summary and just bring it back to you, right? Especially for neuroendocrine tumors, because I know it's a long journey. So I think it's a very great opportunity, and hopefully we can do this together. So we're going to pull this out hopefully soon with Cnets to try to recruit patients. And again, we want to invite patients to come to our meetings, to our retreats, to talk to them. Maybe, hopefully, I would really love to have patients coming and talking during our retreats and during our meetings. I would love that. We want them to be involved in every part of research. And believe me, you know more than anyone else about your disease. All right, so this is a very big team, interdisciplinary team, and first I really want to highlight the work of Dr. Nilakshi Kulathunga, which is a postdoc, and Zoe Wang. Nilakshi is at the very back, and Zoe at the very front here. Really, they started all of this, and sometimes I tell them stop, don't do something, and they don't do it. And believe me, they have some data that some experiments I would have dropped, and they didn't. And that's the determination between a 20-year-old and somebody who went through this whole thing. But it's good, and I think it's interacting with patients will make them even more motivated. And this is really important, and we're going to do it. I was at the right time and the right place to start this. I have to say that a lot of this infrastructure, it was there or it was ready to be built. Dr. Simro Singh and Dr. Calvin Lowe and Julia Hall, they've been there for so many years. The clinic was there, the volume of patients. We wouldn't have been able to do this anywhere else or in very few places. And of course, my colleagues, they built all this fancy robotics and all this equipment. So I'm very thankful to everybody, but especially to patients and the family members, because again, you have to remember you are the center of everything we are doing. So really, really thank you. And it's a great, great honor for me to be here. And of course, all the founding and especially Cnets. Cnets was my first grant. So, when you open your lab and you don't have any money, you can't hire anyone, you can't do anything. But really getting the first grant from Cnets, after that, it just opened up a lot of doors for us. So it was really, really important. Thanks so much. Thanks for listening.
Questions? Sorry, you don't get away without using the microphone.
Thank you. I'm just wondering, can you use pathology tissue from surgeries from a couple of years back, or does it have to be immediate and flash frozen?
So for all the avatar models we do, we have
Yes.
to use fresh tissue, and also it's very important we get the tissue within hours. That's
Okay.
why you need all this multidisciplinary team. But as I mentioned, we did go back to historic samples, but we're looking at different things there, mostly how to understand the biology. Thank you. Thanks so much, everybody.
Thank you very much, Dr. Michael. Our next presenter is Daphne Lamousserie, and she is a pivot nurse. I believe and she's going to talk to us about nursing and Cnets.
Hello. Hi. Sorry, I didn't prepare anything because I thought we could have a conversation. And I want to say I'm very honored to be here because I admire you guys as patients, and I've been learning a lot from you. So I'm very humble to be here because, you know, I'm a nurse. I'm a pivot nurse. A pivot nurse, what it does, it's something in Quebec. So they put this in place for cancer patients, and so that person, that nurse, is a resource person to follow patients throughout the trajectory of their cancer. So that's the thing. So there's specific tumor site that we are assigned to. I'm assigned to HPB. So HPB, it's the cholangio, gallbladder, pancreas cancer, but the adenocarcinoma. So why am I talking in a Cnet conference? It's because my team, the crazy boys, I call them the Greek mafia because Dr. Mitrakos, a lot of Greek doctors, and there's two oncologists that I'm working with, Dr. Kevin and Dr. Asela. So they are, you know, people that are interested in this thing, and so they grabbed me into this journey. And me, I started to learn a bit about Cnet cancer. So that's why I'm talking today to you, and that's why I know some of Cnet patients, and I know about Cnet cancer. And because I started to learn more, you know, be interested, because of patients coming to me and asking me questions, and my ego, you know, got some, you know, hit. And so I need to know more about it and learn more and also help them through this. And I was able to do so because of the encouragement of my oncologist and my surgeon working with. So that's why. So they asked me to discuss about role of nursing in Cnets. So I'm like, okay. So I'll talk about what I'm doing. And so I think I don't need to tell you the definition of Cnet cancer. I think you've been telling me this, but I wanted to aim highlights on the key responsibility and challenges faced by nurses in providing optimal care for patients with Cnets, because it's challenging. It's good, but it is challenging because actually I know nothing. Again, I'm learning all the time from you. So, but first, I want to start. If I see a patient, so we talk about diagnostic and education. So the diagnostic, a lot of patient doesn't know how it goes and things like that. So I'm able to teach and inform patient about the diagnostic tests, different tests, like the nuclear medicine test with the dotatate, the PET scan, what it means. So all of this education, it's to give them pamphlet and help them understand what it means. And it's really true. I love, because of, again, conference of Cnets, I learn about the zebra and the meaning. So I love telling that story to patients. They are fascinated. And I really love that story. And it's a beautiful way to really highlight how complex, different, and rare, but at the same time, it's the voice that we heard. It's still cancer, So I tell that story so it can at least inform them and help them understand what kind of journey they're going to start and where are we going to start and why aren't we starting chemo right away, why sometimes we are very, not laid back, but, kind of cool and telling them step by step. So this include explaining the various diagnostic tests, such as imaging studies, blood tests, and biopsy. And so also nurses can provide emotional support and address any concern in misconception patient may have promoting information decision-making. So that's kind of the first step when I meet a new patient, because the doctor mention them what's going on, but I take that time with them. Some patient that's here can tell me if I did right the first time. So then you come with treatment management and support. So the treatment management, a lot of treatments, and that too was why I wanted to learn more and be more present for patient in that role, because a lot of treatments are oral treatment or injectable, you know what I'm talking about. So because of that, because the role is support and being a resource person, I wanted to be there for patients. So I don't know what's your experience some other places, but that's what I hope I've been doing for patients. But also the key for this, it's really to be in contact with the PIVO nurse or with the nurse, because in this world of medicine, unfortunately, you are unique with what you have. This is a long situation, a long journey, so you're not present like different patient every 2 weeks or every week in clinic having IVs. So having injection or oral treatment, it's important to reach out, to use the support, and I don't mind being used. So to do so to help, manage treatment-related complication, education on self-care, medication management, lifestyle modification, ensure that the patient also have adherence to the treatment, because you're home with the treatment oral, so sometimes you can be discouraged or not wanting to pursue. So that too, being informed properly, knowing about the side effects properly, and knowing that you can reach out to someone that maybe can help to keep going. And a lot of research that I love to use is, of course, I call it the Bible, the Cnets booklets. Really, it's a must for everybody to have it. I use GEOC. It's a Quebec website. If you're in Quebec, it's in French. I use the CCO, Cancer Care Ontario, to get information and to print out. And I use BCCA. It's the Cancer Care Ontario, it's bilingual, so it's fun to have the English and the French part. And the BCCA, it's only in English, because I'm in the English side, so I have a lot of English patients too. So I can print out information and give them hands out for the treatment modality. So treatment management support, and then I do symptom management, treatments, like side effects. And guide them throughout the trajectory, because trajectory can be included social worker, can be included palliative care. And for me, palliative care is not, oh, you go to palliative care, I'll let you down, because again, it's a chronic situation, it's a long journey. It's palliative care, it's support. It's to help you have a better quality of life. So I feel earlier that you are part of this care, because it can help you with nutrition, with pain, with different side effects. So palliative care do help for quality of life also. So I like to tell patients about this early in the journey, especially if they experience side effects, that I feel that team can help better and support more. And you can be discharged from palliative care. You can be 5, 10 years in palliative care. Anyway, with my team, that's the way we think, because again, it's a journey. And you need quality of life, and you are living. So it's part of it. And in the umbrella of palliative care, they have rehabilitation. So they call it the rehab clinic. So it's a place that there's a nutrition, there's a physio, there's a family physician, a doctor that help patient in this. And because of the team that I have, and because we do have a lot of cancer patients with neuroendocrine tumor, we did do a lot of referral to them. So there's a connection with that clinic and us, and they develop a lot of insight, and they become very eligible on how to help NET patient. And they do understand, those patients have a life after that. It's not just that part that they have pain. Yes, maybe the disease is a bit more stronger, or we need treatment, but then after we can continue. And especially now with all the treatment modalities that we have, so it's even better. And so by sending patients and more to those places, more and more also other groups know how to help and deal with Cnet patient. Because again, when I started, it was very uncommon, but now it's becoming more and more. I don't know why. Yes, I feel I know more. It's because we live longer. It's because now the tests are more sensitive, and so people are becoming more aware of the disease, and we can do diagnostics sooner than later. So we see more patients. So we're seeing them more and more. So it's rare, but it's becoming more, common in a sense. And again, you go back to life with working with, your day-to-day life. So we need to be more sensitive to this, and we need to send more patients to different groups so they can help better. So education and research. So I do like to be knowledgeable about what I don't know. So I like when patient comes to me and educate me, because that's often what you guys do, just so you know. And I'm more than happy to receive this. And then what I do, I go and ask more questions. More and more also the opening for research. I know, for example, I have a young patient with, since 2016, he has Cnets, grade 2, and we did send him to the germline testing, because it's a pancreas NET. And germline testing, we do that with the adenocarcinoma pancreas. Because he was young, we thought, I did. I asked if he could go and be tested because he's young, and we discovered for him he's BRCA positive also. So that, in 2016, we had that information, and today we can use it for him. So that was, very fun and nice that my team was open also to receive and test this patient. And in part of because we have a study for germline testing in adenocarcinoma, pancreas cancer. So that was nice of them to open. So that's part of what nursing does also, advocate for patients and knowing, being knowledgeable of, being informed about what's available. So that did help me encourage and talk to my team and asking questions. And also the patients that ask me questions that I look smart after because I go back to my team and they're like, but they don't, I never tell. They don't know it's my patient that asked me. But it's fun because of you, I get to be smart, thank you, and ask questions and help you out. So this is part of working as a group, working as a team, and advocate for patients. So this is, and it's challenging for me, but it's fun because I love learning and you teach me a lot. Thank you. I'm going to conclude because I feel that I'm boring you. And so in conclusion, I think nurses, we play with the patient a good essential role in the trajectory of this journey, cancer, especially for NET patients, because again, you guys are the voice, and I'm very privileged to have, and to, I think it's the patient. I'm thinking of one patient that really brought me those things, information. I think that's what helped me and helped me help you. So if people doesn't have, because we don't have specific nurses for NET, so don't hesitate to ask questions and, continue pushing, because someone would listen and would want to know. And this is part of the nursing role, in oncology. This is what we do. So you should not be, or you shouldn't hesitate to just ask and push for more information and more support. So that's it. Thank you. Yeah.
Do you have to have consent from the Greek person?
Consent, in a sense, to see me, for the patient to see me. They refer, so because they go to the doctors, so the doctor referred to me, but I have some patient that emails or call me or just ask, is there someone that, I do have that, and then but I do need, because I'm a nurse, I'm not a doctor that, so I'm within an institution. So I have to follow the rules of the institution. So Miranda is here. I used to work with her. I love her.
Okay, I don't have a question for you, but I wanted to say Daphne gave all the technical things that she does, but she forgot to say that it's her heart, her connection, her passion with the patients that makes all the difference.
But really, it's really coming from the patients. I'm humble and lucky, because I wouldn't be able to do anything if the patient didn't push me. Really. And the patient come to the clinics or to the group, but then after, the patient see the doctors, NETs patient every maybe 6 weeks or 6 months, but in between, patient can call me, email me, and have a conversation. And I don't discharge patient. I say one of my patients that didn't see me for a long time, but anytime he calls me, hi, I don't mind. So it's you I was talking about.
Yeah, so for me, it's more a comment and a question. I just want to say that I believe that many of us in the room have already dealt with Daphne at what point or any other in their journey, and I think she is great. She's a pearl, and we should have more of Daphne in the system. That will be awesome.
Oh, thank you. Thank you. But it's not easy. It's very challenging because I don't just have this site. So, and I don't always have the answer, and it's not always easy. But I feel more and more there's interest, and more we see things happening. Like more and more there's new treatments, like Lutathera. Hey, now it's like out there. And we're doing it kind of everywhere now. Before it was, anyway, for Quebec, it was just in Quebec City with Dr. Beauregard. you know? So we are becoming more privileged. And it's nice that people take more interest in this tumor site. And it's because of you, really.
Okay, Daphne, I understand that if other hospital or other medical group would want to have somebody like you, they have to ask and work around the...
I don't know. There's not, see, neuroendocrine tumor is not something like they categorize in. So maybe if you have a pancreas neuroendocrine tumor, you'll be associated with the pivotous with pancreas cancer, you know? Maybe. So it goes by tumor site.
Okay.
Me, I kind of don't do that because my group asked me to be involved, but that's like if it's a colorectal neuroendocrine tumor or rectal, so you will be associated with the pivot nurse in that hospital who does colorectal. But it's not necessarily the thing because it's not everybody when they see neuroendocrine tumor they don't
Yeah.
understand.
But I've been with you
We've been
since
together.
close to 9 years now.
Yeah.
And you helped me understand some of my treatment or some of my diagnostic test. Okay, why one says something and the other one didn't say the same thing, stuff like that helped me with all kinds of
CLSC.
stuff. Yes, yes, refer me to the CLSC. So thank you, and I wish everybody around Canada could have a nurse that knows about NET, because it's not a pancreatic cancer that we have, it's a PNET, you know.
I do.
So
Yeah.
Bonjour Daphné, moi je vais te parler en français.
Oui, oui, allez-y, s'il te plaît.
Je m'excuse parce que mon anglais est affreux. Je veux pas écorcher les oreilles. Mais en fait, on va se voir jeudi en passant. Mais on s'est vu il y a 1 an et demi quand j'ai été référée à un de vos docteurs, Dr. Cavan, pour ne pas le nommer. Et je veux te remercier parce que c'est toi qui m'as donné le dépliant explicatif de Cnets Canada. Puis grâce à ça, j'ai pu me joindre. Sinon, je ne suis pas sûre que je l'aurais trouvé si rapidement. Donc, j'ai fait mes traitements dans un autre hôpital. Puis même les oncologues ne connaissaient pas. J'avais le support de Dr. Cavan avec mon oncologue directement, mais ils sont super fines, les infirmières pivots, mais toi, tu vas au-delà. En tout cas, je voulais te remercier puis te dire que oui, tu vas au-delà parce que même quand je parlais à mes infirmières pivots, oui, mais toi, tu as un cancer spécial, je ne connais pas vraiment. Elle n'était peut-être pas apte ou c'était pas dans ses charges d'aller vérifier, mais tu as cette curiosité-là qui fait que pour nous, c'est un beau cadeau. Puis encore merci de m'avoir remis ce pamphlet-là parce que ça a changé vraiment ça m'a aidé à progresser plus vite dans la connaissance de ma maladie. Puis, tu as toujours répondu aussi à mes questions quand, tu sais, il y a une série de tests, là, on ne les fait pas toutes. Fait que merci, c'est plus une innovation à toi. Merci d'avoir été comme ça avec moi. On ne s'est pas vu souvent, mais tu m'as beaucoup aidé dès le premier jour. Puis ça, c'est quelque chose.
Il faut m'appeler.
Mais maintenant, je vais t'appeler. Tu vas voir, on va se rencontrer jeudi.
Mais this is what I was saying. The nurses in oncology, like there's no specific for neuroendocrine tumor. That was my own interest and also my group that was pushing me. And I developed this. It's not easy. It's like I said, it's very challenging because more and more is becoming, you know, and the treatments also are more, there's more to do. And the Bible, it's important to follow and it's important to give it. If Cnet can have more and distribute that more to different places, that would be perfect. At least if the patient at the first time at diagnostic received this, that would be a great help. Just that will be a beginning. Yeah. Miranda.
I just wanted to tell you, so I work with Canadian Cancer Society, and we're working to change Statistics Canada's classification of NETs, because right now they're grouped into pancreatic, etc., and it's not. So hopefully, if that changes, it would be an easier time to identify the tumor sites that need a nurse.
Yeah, maybe, yeah, that's a good idea, actually. So they can pick, okay, you do pivot for this, because breast, you do breast for, so lung, but neuroendocrine, we don't have something specific. I know at the CHUM, they have a nurse there in nuclear medicine for the Lutathera treatments. But she just see patient in nuclear medicine for that specific type of treatment. And in with the endocrinologist, there's nurse there for endocrinology, but not specific for NET. So it depends. Maybe someone will take interest more also.
Daphne, would you have your email, please?
Yeah, I can give it to you.
No, I have a phone one. I don't have an email.
I give you my email.
I'm sorry.
Yes.
Working with one of the doctors on the oncology, I'm with Dr. Estela,
Okay.
and I was treated for 2 cancers, one for the colon, so I have my pivot nurse
Yeah.
for the colon. But are you specifically for the pancreas
Specifically.
or for any other TNE?
No. Actually, I'm not for TNE at all.
No,
It's.
but your research that you're doing by your own,
Oh yeah, I know.
very curious, is this specifically for
No.
pancreatic, or you can go for the small bowel?
Yes, I can.
Okay.
But because you had a pivot nurse, I don't mind if you ask your pivot nurse to ask for me. It's no problem. I can give you my number. She's wonderful.
Yeah, but I'm going to change setting too much. So I don't know, she mentioned to me I will meet her at the end of the month.
We can talk after. Yes, there's a new nurse coming. And yes, I do follow. Again, I see pancreas, I see gallbladder. So it's challenging, it's a lot. So if there's, in my institution, if there's someone for colorectal and it's a colorectal net, so usually what I say, I can guide her if she needs, but I would not necessarily take in charge the patient.
But she was very specific for the cancer.
Colorectal, yeah,
And this is what I had. Now it's gone.
it's gone.
Yeah.
Now you have a net,
I have a net on top of that. So they removed me the 2 months.
and is it a unknown primary or?
The primary for the mets that I have on my liver is the nets. It's
Oh.
yeah.
Okay,
The colon. The colon.
it's not colon,
No.
I have
two type.
type of cancer.
I think I understand because
Yeah.
in order for us to broadcast this, you have to speak into the microphone. And I know it's kind of a personal question. You didn't want me to give you the microphone. We do have a networking time frame now for people who maybe want to speak to Daphne personally, to maybe understand some of this. I think one of the questions I would have is exactly that, because pivot nurses are assigned to a particular cancer.
Cancer,
There's the net patients have to go to that person and then request maybe to see other pivot nurses, which
Yeah.
presents a networking.
And
difficulty.
and a lot of time it's because if let's say it's not one of my tumor site that it's a net, if the patient started treatment, I like to be involved a lot of times because I'm like, okay, I don't mind doing the teaching, like for the captain, for Evolumus or certain, different type, and so that's okay. So maybe we should talk after.
Is there any other questions for Daphne at this point? Okay, then we'll start networking timeframe. And just in case anybody is ready to leave or anything, please note that if you're parked here in the Queen Elizabeth, there's
A voucher.
tickets to get out. Okay, that's all. And they're at the front where
Thank
Rico
you.
was.